So we'll start out with the first case. This case was actually requested by the parents to be discussed in today's meeting. I don't think Dr. Ramesh Kunanki is with us today. So this child initially presented with infantile onset epilepsy, had these 4 ill-defined hyperpigmented macules in the chin, along the legs and arms, and along the abdomen. These changes resolved by 1 year of age. So now the child doesn't have these hyperpigmented macules. Presently, the child is 22-month-old with mild expressive language delay. EEG at 3 months had a liability to develop centroparietal seizures. Seizure-free since 1 year, past 1 year, and the child has had left hand preference. So this is the initial scan at 3 months of age. On top, we have the T2 axials, and you can appreciate these asymmetrical confluent white matter abnormality. Yeah, Dr. Lokesh, you're saying something?
No, it's okay.
Okay, yeah. So we have these asymmetrical confluent white matter abnormalities, predominantly in the left frontal region, and also extending up to the temporal and occipital regions on the left cerebral hemisphere. They demonstrated these changes of rarefaction on flare sequences. There was no mineralization, maybe tiny foci over here, but this is difficult to ascertain if it is a vessel or a calcification or mineralization. Diffusion demonstrated these cortical areas of restricted diffusion and also in the white matter and the cingulate cortex. Post-contrast study, there was no enhancement in the abnormal areas. Spectroscopy did not demonstrate any diagnostic peaks. So given the hyperpigmented macules and these changes, clinically, they thought of a neurocutaneous disorder. Tuberous sclerosis was high on the clinical differential, though the imaging did not match with the diagnosis of tuberous sclerosis. Later on, after 4 months, the child again had a repeat scan. And as you can see, the white matter changes have now slightly regressed in comparison to the initial study. There are still residual areas of abnormal high signal changes in the white matter, predominantly the anterior periventricular regions. Nothing in the posterior fossa. But on the SWI images, you can appreciate these tiny foci of abnormal areas of blooming in the bilateral cerebral hemispheres involving the white matter and the subcortical and cortical regions. The left cerebral hemisphere is demonstrating the subcortical areas of tiny blooming foci and also involving the bilateral basal ganglia. At this point, the child had a genetic test, a clinical exome sequencing for neurocutaneous disorders, which did not reveal any pathogenic variants. Follow-up scan was done last week, and you can see that the white matter changes have again improved in comparison to the prior study, though there are some residual areas in the periventricular regions with some degree of volume loss. But the overall white matter changes have improved, but now the areas of calcification have progressed in comparison to the 7-month scan, and you can see that the bilateral basal ganglia have now more confluent areas of abnormal mineralization, also involving subcortical and cortical regions in the bilateral cerebral hemispheres. CT scan was done on the same day, and you can appreciate these coarse and punctate calcifications involving the deep gray nuclei, the subcortical and cortical regions. So once I saw this scan, it was reminded me of this case which was presented in October. This was a 2-year-old female from Dr. Kavita, had microcephaly, hypotonia, global developmental delay. Again, the child had these asymmetrical confluent white matter changes, now also associated with cerebellar atrophy. And there were some areas of abnormal mineralization in subcortical cortical regions and the deep gray nuclei, better demonstrated on the CT study. At that point, we thought of a possible diagnosis of interferonopathies or Cockayne syndrome. So these are the differentials for the deep gray nuclear calcifications and also the subcortical cortical calcifications. So intracranial calcifications in our case has these white matter changes or possible differentials of Aicardi-Goutieres syndrome, Cockayne syndrome were high on the list. And these are again from literature, the imaging phenotypes of the various subtypes of Aicardi-Goutieres syndrome. These are from the paper published last year in the AJNR. Dr. Mankad is one of the senior authors for this paper. We don't have a diagnosis at this point. The child has been sent for whole exome sequencing last week. And at this point, I'll open the case for further discussion.
I think Aicardi-Gouttiere syndrome is a very good suggestion. This is high on the list. Was CSF examined? Is there a pleocytosis?
No, I don't think CSF was done recently. Neopterin assay also wasn't done. They have directly sent for an whole exome sequencing. Clinically, just a question from a radiological point of view, are the hypopigmented macules common, and do they resolve by completely in Aicardi or interferonopathies?
Aicardi, generally you don't have cutaneous markers much, except for something like chilblains during the acute episode time. But otherwise, you don't get this kind of hypopigmented macules. These are usually seen either with TSC complex or your hypomelanosis of Ito, those kind of differentials. And they're not following the lines of Blaschko as well.
Yeah.
So not very typical. The extent of basal ganglia complex calcification, is it common to be seen with Aicardi? Just
so these are examples of it from the literature. You can see that the calcification in the basal ganglia and the subcortical deep periventricular white matter. So I think it can be seen in Aicardi-Gouttiere. The other differential is cocaine syndrome with these deep brain nuclear calcifications and parathyroid related disorders. But I think we are moving towards the interferonopathy or a cocaine type of picture of the MRI. Hypomelanosis of Ito, clinically yes, but they don't show calcifications as seen in our case. So imaging does not.
Such early calcification and thank you.
Yeah. Okay. Right. Thank you. The second case is from Romit. Romit, are you there?
Yes, sir. So this was a 4.5 months old girl. She had an acute febrile illness associated with gastroenteritis and severe dehydration. And day 2 of illness, she started having seizures. She had refractory seizures, had to be loaded with 3 anti-epileptics, and then started on midazolam infusion. And that's it. So on examination, she had subtle hypertrichosis, mostly more on the forehead, and she had cortical vision impairment, poor tracking to light. The lactates were raised in the VBGs. We didn't do a blood lactate separately, but in all the venous blood gases, lactates were raised up to 4 millimoles. And she didn't require, although she had severe dehydration, she was given fluid correction, but no inotropes were required. And TM's urine organic acids were normal, and CSF analysis was normal. So I'm sorry for the poor quality of the MRIs, but
no issue. Yeah, thanks. So the MRI is done at 4.5 months, and what we can appreciate in the bottom panel, first we can see that there are symmetrical hyperintensities in the panel. If you can see what's so problem. These demonstrate restricted diffusion with reversal on ADC sequences. The supratemporal vein parenchyma, there are widening of the subarachnoid space expected. Nothing in the DBI is a normal size for a 4.5-month child. So primary findings are dorsal brainstem abnormalities and the symmetrical abnormalities in the dentate nuclei. So just for radiologists, I could find these differentials for hypertrichosis. These are the common conditions presenting with hypertrichosis. And the imaging pattern, the differentials are wide for the dentate nuclei abnormalities. I would go with mitochondrial disorder presenting with hypertrichosis and dentate nuclei and brainstem abnormalities as the first or initial differential. SERF1 mutation, complex 1 deficiency, and short chain enol coenzyme deficiency can present with the hypertrichosis and these changes in the cerebellum and brainstem. At this point, I'll open the case for further comments.
Generally, hypertrichosis or even alopecia both can be seen in mitochondrial cytopathies. And failure to thrive associated with that, and the elevated lactate here probably is more pointing towards a mitochondrial cytopathy. But did the lactate improve quickly, Romit?
The lactates improved in 48 hours, sir.
Yeah, reasonably quick. Okay. And so currently the child is back to baseline?
Yeah.
No, sir. The child has cortical vision impairment. There's poor tracking. The child has regressed in the sort that the child is not doesn't have any social smile, has no recognition, has loss of head control. But whether it's a single point regression or part of a neuroregressive disorder, not.
Okay. But now this is an acquired condition for me, and whether this hypertrichosis is related or not, I don't know. I mean, this is not unique, I think. You see from time to time children with abnormal hair. I would not yet be prepared to call this a mitochondrial disorder. And at 4 months, sometimes venous lactate measurement are delicate and are false high.
Any positive infective markers, Romit, on labs? CSF, I think you mentioned as normal.
Nothing, sir. We have sent genetic testing, means whole exome and mitochondrial.
Because given,
but the TMS didn't show any raised alanine or that sorts, means to get a clue of mitochondrial cytopathy. Rest of the investigations were normal.
So I think what Agan was suggesting, that a possible Raman encephalitis can also be presenting with similar imaging findings. Is that right, Agan?
And also there seem to be a lot of white matter involvement. I don't know. In these set of images, it's not seen. There was a lot of white matter involvement.
Yeah, the only thing, it's a 4.5 month child. We have to keep in mind that the myelination is not there at this stage. Yeah.
So you may consider to repeat the MR in whatever 2-3 months and see how the clinical situation evolves. I mean, this child had severe dehydration and multiple seizures.
Sure, sir.
Sure.
Okay. Right. Thank you. Yeah. Next case for me.
Yes, sir. So this was when the child presented to us. The child was 1.5 months of age, born preterm, 33-weeker, low birth weight child, 1.6 kgs at birth, had normal antenatal events, and was admitted initially just for observation for low birth weight, very low birth weight, and child developed respiratory distress while under observation in the ICU, and then child had to be intubated because of severe respiratory distress, and the child became completely encephalopathic, became cyanosed. There was poor state-to-state variability, and child improved after 36 hours of intubation. The child was extubated, and since then for 1.5 months, whenever they try to feed the child becomes intermittently cyanosed, and for next 24 hours or so becomes encephalopathic. So very odd sort of history. And she developed multifocal seizures during multiple episodes, means very intermittent. There will be cluster of seizures during that encephalopathy period, and and she'll be seizure free for next 5 days or so. So intermittent encephalopathy, mostly associated with feeding, and prolonged encephalopathy. On examination, head circumference was normal, no dysmorphism. There was central hypotonia and poor neonatal reflexes. CSF analysis was done, which was normal. PCR was not sent. Metabolic workup in the form of TMS and urine organic acids were normal. VBG was normal. Blood lactates were normal. And every time the ammonia levels of the child would be about 200 to 300. They never crossed 300, but it would be about 200, 220, and so on. And in the one of the centers before the child presented to us, the child even required sodium benzoate to reduce the ammonia levels, although the LFTs were normal every time. So we sort of are in a fixed state, whether to consider it a metabolic disorder or it's some other genetic epileptic encephalopathy.
Okay.
And actually the child was discharged a week back, and today the child is again readmitted, and the ammonia levels today is 158. Before discharge, the ammonia levels were sort of 25.
Okay. So these are the images at 35 weeks, I think 1.5 months after. So yeah, around 35 weeks gestation. The gyration is slightly widened, but this is normal for a preterm child or a 35-week-old. The plics are partially myelinated, again normal for a 35-week child. I cannot appreciate any structural malformations, no signal abnormalities in the deep brain nuclei. Tiny foci of T1 hyperintensities in the white matter over here, minor ischemic changes. But other than that, I cannot appreciate any significant abnormalities. Corpus callosum is normal for the age. Brainstem and the vermis is also normal for the age. The images are slightly distorted, but the question was, are these areas of restricted diffusion in the central white matter in the pyramidal tracts? They show corresponding low signals on the ADC sequences, the anterior and posterior limbopetal capsules. These are artifactual. The parieto-occipital region demonstrates these artifactual changes. But I think these changes in the central white matter, given the reversal of the ADC sequences, can be taken as pathological. Differentials are slightly wide again. Spectroscope wasn't done. We could not rule out NKH. ITP encephalopathy can present with these changes, but they usually have facial dysmorphism and respiratory issues, if I'm not mistaken. We have seen changes in hypernatremia. I don't think child clinically presented with that. Doesn't fit with MSUD. Other mitochondrial disorders in the tRNA-related abnormalities can present with these central areas of restricted diffusion. So these are few differentials, and I'll open the case for further discussion.
Nihaal, is the restricted diffusion a real finding or is it an artifact? I think there is a bit of generalized white matter swelling. Is that right in your case? Because if you see the pons as well on the sagittal, the differential signal is quite high in the ventral aspect of the pons. So there might be a situation of generalized white matter hyperintensity out here, which could give you those diffusion changes in itself, right? Without it being typically an internal capsule change only. So if you just look at the posterior aspect of the cerebral hemispheres, particularly on the left, on that second axial T2, and then you just look at this areas here, a little bit of what you're seeing is probably artifact on diffusion, but I think there is generally a white matter hyperintensity.
Okay.
Which could go with the raised ammonia story, isn't it?
Yeah, hyperammonemic encephalopathy. Yeah, I just wasn't sure of the diffusion changes and the white matter changes, given the artifacts. But
yeah, because if we call the internal capsule there, we'll have to call a lot more in that brain in terms of diffusion changes.
So the lactate, the ammonia cutoff there is 90, is it, from it?
Yes, sir. So,
okay,
like for neonates, we only consider above 100. It was never very high. Like for sodium benzoate, we usually start giving after sort of 500 when children become encephalopathic. It was always 200, 220, sometimes up to 300. And I even talked to Dr. Kariappa. He said that the normal TMS, it can't be urea cycle disorder.
So, and also encephalopathy usually is seen. You see encephalopathy, not seizure as a primary manifestation, recurrent vomitings and encephalopathy, rather than seizure as a primary presentation.
Child becomes intermittently encephalopathic, very poor state-to-state variability. So whether it was the transient hyperammonemia of the newborn, like, so not sure of the diagnosis here.
Yeah. At least radiology is not giving any diagnosis, and the ammonia levels probably need to narrow it down.
Romit, no
consistently.
low glucose levels, right? Just to rule out hyperglycemia.
Sorry, sir.
Glucose was normal, I guess.
Yeah, glucose was normal.
Okay. Because if I'm retrospectively seeing the cortex over here, I don't know if you agree, Dr. Mankad is slightly hyperintense as compared to the temporal and frontal areas. If this is
Yes,
some degree
I
of
agree.
necrosis.
I agree, and that is why when you see the T2 as well, the cortex is actually thinned out. The gray ribbon is maybe interrupted in parts. We don't have the full study to scroll here.
Yeah.
I also wondered about the spinal cord in that sagittal T2, but that cannot be confirmed on the scan.
No.
So what is your diagnosis, your suspicion? Is this metabolic, urea cycle, or just an intercurrent?
Given day 2, day 3 deterioration after starting feeds and raised ammonia and encephalopathy, our initial diagnosis was urea cycle defect. But given now the metabolic workup is negative, we'll have to rethink.
So lysinuric proteinuria, a urea cycle defect, can present like this, and you can have a normal TMS and UA. So you should definitely think of it.
Okay, right. But they usually present with diarrhea and
No. They present with, so our patient, which we had reported, that patient presented only with episodes of encephalopathy from 6-month age. TMS urine OA couldn't pick it up, and then the genetics picked it up. Lysinuric proteinuria the child had, and ammonias will go up to sometimes 500 also, sometimes 200 to 400. And when he became older, he will be insomniac for days, and the TMS and urine OA was not showing as much problem. I think when we asked them to look at the TMS closely, so then, and when we told them lysinic proteinuria was a possibility, then they looked at it again, and then he could tell us something, Dr. Karyappa. So you can ask him.
Right. I'll ask, sir.
Okay. Thank you, Dr. Vivek.
Thank you, sir.
Next case is from Dr. Rashmi. Dr. Rashmi, if you're there, you can take it forward.
Yeah, 1 second. Okay. So, yeah, so this is a very interesting child. Can you hear me? Can you all hear me? Yeah, I was going to, yeah. So this is a very interesting child. It's a 6-year-old boy who initially presented to us 1 month after the episode. So he started off with deviation of the angle of the mouth. So he was seen in Orissa by a local pediatric neurology there, diagnosed to have facial palsy, and then started on steroids and asked to do MRI brain scan. Then they gave the steroids on and off. They did not give it fully. They felt it got a little bit better. But 2 weeks after that, he started having weakness of the left upper and lower limb. So he was stamping his left foot. He found it difficult to wear his left slippers and all of that. Then they were again dilly-dallying what to do and all that. Finally, they came to Bangalore because father works here. And 1 month after the initial facial palsy, he presented to us. So when he presented to us, he had left hemiplegia and right upper motor neuron facial palsy with normal sensorium. So after the MRI brain, we thought that he had acute demyelinating syndrome based on the MRI. So we started him on IV steroids, methylprednisolone. Of course, we did CSF analysis. We sent off oligoclonal bands. We did MOG, aquaporin 4, all of that we did before starting the steroids, paired oligoclonal bands we sent. And then after the steroids, he became encephalopathic with altered sensorium. Then after that, we gave him IVIG as well, and then he slowly improved. He slowly improved to an extent to which that he is responding, he's eating and drinking, but he still has a lot of trouble with vision. So his fundus examination after steroids and IVIG was normal, but the ophthalmologist said that he could have retrobulbar optic neuritis. When he had altered sensorium, we did EEG, which just showed normal sleep activity, spindles and vertex, no epileptiform discharges. CSF analysis, 3 cells, protein and sugar was normal. And CSF blood and oligoclonal band shows type 4 pattern. So same bands in the CSF, so no intrathecal synthesis of IgG, indicates systemic inflammatory process. his vitamin B12 was normal. He had low vitamin D. Lactate was initially 4.7, and which subsequently normalized. So at the moment, he's still having vision problems, and in fact, we were going to go third line and start him on IV cyclophosphamide tomorrow. But I wanted to discuss his MRI scan today.
Okay. Clinically, you're thinking of demyelination, Dr. Rashmi?
Clinically, we're thinking of acute demyelinating edema only, because edema can progress over 3 months, correct? There's a 3-month window period where the changes can progress. So clinically, we're thinking about acute demyelinating encephalomyelitis, but then we miss the first month window to start treatment early. That's one. And secondly, it's very severe. He's not, his vision is not recovering at all. So he seems to be very, very severe.
Okay.
What is the MOG?
MOG and aquaporin 4 both are negative.
Okay.
Negative. Okay.
Yeah.
So just for the radiologist, so we have type 4. Is this the one we have?
Yeah, this is type 4. Yeah, this is what they said. Identical oligobranch CSF and serum indicates systemic immune reaction with passive transfer, no intrathecal IgG. This is exactly what we suspected.
Yeah. Okay. So it does not. It's not diagnostic for multiple sclerosis, though it's a single.
Yes, because our radiologist, when he saw the MRI, was thinking that certain features could be consistent with multiple sclerosis, which is why we made sure that we sent this in the CSF and the blood before we gave the steroids.
Okay. Okay, we'll go ahead with the images.
Yeah.
So here we have the flare and the diffusion weighted sequences. On top is the flare sequence, and you can appreciate these multifocal, partially confluent areas in the bilateral cerebral hemispheres involving predominantly the white matter, the corpus callosum, some tiny focus in the right thalamus, the periventricular regions, deep white matter, also involving the brainstem, the dorsal brainstem. On diffusion weighted sequences, there is peripheral areas of restricted diffusion. I correlated with the ADC, and they demonstrate low signal changes, so the images are not there at the present. On T2 weighted sequences, you have the heterogeneous T2 hyperintensities involving the lesions in the bilateral cerebral hemispheres. Some areas are confluent, some areas are patchy and focal. You can see the involvement of the corpus callosum. There is some degree of volume loss in the vermis and supratemporal vein parenchyma, but not very significant. Say sequence of the optic nerves do not demonstrate any edematous changes. Post contrast study, we have
Dr. Nihaal, because the ophthalmologist seemed to think
on the non-contrast sequences.
Oh, okay, fine, okay.
So post contrast images, you have these fluffy areas of enhancement. Some areas demonstrate incomplete enhancement. Better demonstrate on the sagittal images, and the optic nerves on both sides. You can appreciate peritonitis on both sides, involving almost the entire intracanicular portion of the optic nerves. So there is optic neuritis on both sides with these patchy areas of complete and incomplete ring enhancing lesions. So given the MR pictures, the differentials one could think of is, as Dr. Rashmi has mentioned, clinically ADEM is one of the primary differentials for this case. This actually reminded us of a previous case, which had more fluffy or nodular enhancement, but this child was positive for MOG. The differentials for the various demyelinating disorders, I think everyone knows that, but given these lesions, the ADEM variety can be seen in our case, which is similar to the findings presented in this picture. MOG antibody-related disorders can also present with these large confluent poorly demarcated lesions. Some demonstrate these leukodystrophy type pattern. So MOG antibody-related ADEM can be a differential. Infective MS was less likely. Another case which was discussed previously was from Dr. Vivek, which was a case of Neuro-Behçet syndrome. There were some areas of enhancement which was similar to our case, but the edema was not as significant as our case. But as you can see, there are multifocal lesions demonstrating this incomplete and nodular enhancement. So this was a case of Neuro-Behçet's. This is an algorithm published from Gauche for diagnosing these demyelinating conditions. At this point, I'll just open the case for the discussion.
Yeah. So aquaporin 4 and MOG is negative, and we are almost now 6 weeks down the line since his first, since he first started with the neurological problems. And after extensive discussion, we've decided to go ahead with third-line treatment, cyclophosphamide, tomorrow. I don't know what others feel, because he's not regaining vision, and our ophthalmologist said, oh, he may not regain vision. I don't know. I didn't feel very comfortable about that. I thought we should give it the best shot. So.
I'm not an expert, but I think treatment escalation in this situation makes sense.
Yeah.
Even consider plasmapheresis. But
yeah, we thought about that as well. We thought about plasmapheresis as well, but we thought we'll give cyclophosphamide a couple of doses. If he doesn't respond, then we will go for plasmapheresis. That's what we thought.
Plasmapheresis works faster, and I think experience is better with plasmapheresis probably. So I think that will be better to start off with plasma, because it's a question of vision. Better to start off with plasmapheresis in between a day of gap. If you still want to give cyclophosphamide, you can give one pulse in between.
Okay, so you suggest that we go for plasma, but we've given IVIG, right? It's 2 weeks since
how
we've
long
given
back? Yeah, 2 weeks is fine. So yeah.
2 weeks, it will not take away all the IVIG, the plasmapheresis.
No, by now it has been redistributed. I don't think so it will be in the system. Yeah.
I think the pore size also will be different, isn't it, for plasmapheresis filters. It wouldn't filter out the IVIG or any of the monoclonal antibodies for that matter.
Okay. So it depends on what pore size you use for the plasmapheresis.
Yes, absolutely.
We were discussing a lot. After discussion, we thought we'll give cyclophosphamide tomorrow. But if everyone here is suggesting plasmapheresis, then I'll have to rediscuss it with the parents.
So Rashmi, did the child have fever during the illness at the start at all?
No, no fever. No. When
you
he
won't
started
call it ADEM. So you won't call it ADEM. Is it right? Am I wrong or am I right?
I called it as acute demyelinating syndrome, but he became encephalopathic after the steroids.
So it's a clinically isolated syndrome.
Huh.
So yeah, because there was no fever, right?
Yes, there was no fever. Yeah.
Right. The second thing is, this is looks very similar to a Neuro Beckett's case. So you should definitely rule it out, HLA B51, and take the history about the ulcers. You should definitely do. And GFAP, which is the new kid on the block, because there are streaky, when you look at the MRI, there are these alternate patterns, tigroid patterns, which you can see in the white matter. Not in these images, the ones before. No, not this. This is not the patient. These are other patients, right? This is not this patient.
No.
This is the patient. There are more Excel images as well. Initial ones. First images.
They are not contrasted.
Yeah. So you don't need. So you don't need contrast images. So even though textbook mentioned GFAP showing only in contrast images, the tigroid patterns, in our 2 cases, we saw it in the non-contrast T2 image as well, the number 2 image, top second image. So it's not a strong possibility, but that should also be ruled out these days, GFAP, but Beckett's is definitely important. And I really agree with you that you should give cyclophosphamide here and not go for, plasmapheresis and those stuff, because if somebody has been given IVIG, has not made any damn difference. The amount of cumbersome it will be for you to go for the same modality of immunomodulation doesn't make any logic. You should go for cyclophosphamide.
Thank you, Vivek. That's helpful, because we discussed and then came to the conclusion that cyclophosphamide will be better for him.
It's very easy to say plasmapheresis, but it's so difficult to do it in a small child in the setups we have, and the amount you have to consult the parents. And, we have to be very practical, and it's very easy to say it, but I'm not sure if it works, if IVIG has not worked. Maybe after so many days.
Yeah, what we had discussed was that...
I'm not even sure cyclo, but by the experience of NMDA patients where it works even after a year, it's better to give cyclo.
No, we discussed that since the antibodies are negative, the cyclophosphamide acts on a different basic science. If you look at it acts on the T cell, B cell pathway. So they said that will be more beneficial. That's what we had discussed.
Of course.
Thank you so for that. Now, with Behçet syndrome, what test do you recommend that we do for him?
So one is just put in a needle in his skin, a thin needle, mark it, and it should make a small vesicle, pathergy test. Right, that's one test. So just a small 24G needle into his skin. And that is one. Then HLA-B51, right? And ask for the history first, you know, oral ulcers or any genital. You have to look for those ulcers because they might not show up. He's a boy or a girl? Sorry,
it's a boy. It's a boy. It's a boy.
So around the scrotum, you have to see inside, you know, just in the middle part of scrotum. Just do a full examination and ask for the history of oral ulcers.
Okay.
Because the MRI is very much like our patients.
What would be the treatment would differ?
You get cyclo steroid.
Oh, you give
cyclo is the, yeah, and you have colchicine and other things, but IV is cyclo.
Oh, cyclophosphamide only. Okay, fine. Okay.
Yeah, I'm not sure how often one sees. Maybe Nihaal can sell brucellosis, which can have a similar sort of presentation, ADEM-like, like locally isolated syndrome. If you see that often, because we see it in Rajasthan sometimes, because of unpasteurized milk.
Okay, he came from Orissa, so I don't know. Yeah, we can do Brucella test. We can do Brucella antibody. We can do.
But that's something I think radiologists should say that there is something one should, because there's only one case of clinically iso. I could find Brucella in after doing so many. So I don't know if that's something one should. I'm not I cannot comment much, but just a suggestion.
Okay, fine.
Can I come back to your question about Behçet? My experience is close to zero, but I would expect that you have skin or mucosa or uveitis changes over that long time. Have you seen that in your patient?
No, I don't think he has any skin or mucosal changes. But like Dr. Vivek said, I'll have a good look at his genitals and all that. I haven't done all that. But he does not have any ulcers or anything like that. And he doesn't have any other skin or any other changes like that.
So you get, when our patient, you know, the patient they're showing up of the Behçet's, my patient, we were thinking of MS because he didn't have any history of oral ulcers. Only in the second admission, he developed acute onset severe fulminant oral ulcers. And there was no history before. So you don't often get that history from before sometimes, you know. So that's the problem. And only in the second admission, he developed those ulcers. In the first, we were just thinking that this is MS because he didn't have that history.
Yeah, even in this one, no, what our radiologist said was that some of the findings were suggestive of MS. He said not all the findings are EDEM, he said. I think, is it the periventricular subcortical, something he was saying. So that's why we did this oligoclonal bands and all that. So.
See, except for the callosal lesions in the sagittal image, like again, I haven't got much experience because I'm a pediatric neurologist. We don't see that much MS, but this doesn't look like MS.
Okay.
They're too big and fluffy.
Yeah.
The age would be very I mean, in terms of age distribution, ADEM is 5 to 6 years is a peak. So this would fit very well in this boy, more than MS.
Okay, that's a very helpful discussion. Yeah. Thank you very much. Yeah.
Thank you.
Thank you.
Case 5 from Dr. Kavita. If one of the fellows, Sahil or Dominic, can present the case.
Yes, sir.
Yeah.
Yes, sir. So this is a case of 15-year-old girl. She came with complaints of headache since last 5 days, and over the 5 days her headache was initially moderate in intensity. Most of the times it is on right sided, but when the headache is so severe, she used to get bilaterally, and she also developed ptosis and diplopia of the right eye since 1 day, same side of the headache, and she got this ophthalmoplegia and ptosis on the day of severe headache. This is the main complaint. And when we examined her, she has a right eye third nerve palsy, complete ophthalmoplegia involving the pupil that is fixed, dilated, and not reacting to the light. And left eye is normal. No other deficits we found. That's it, sir. So this is the complaint she mainly came to us. So we initially thought of any SOL, compressing the nerve, or any aneurysm of the PCA. So we immediately did a scanning, and after that we ruled out other causes of autoimmune. So we have done the limited investigations like ANA, dsDNA, and thyroid and T2 antibodies that came normal.
Okay. Moving on to the images, the findings are there on the next slide, but just an overview of the supra and infratemporal brain. There are no abnormalities in the supratemporal or infratemporal brain parenchyma. Corpus callosum is normal. Brainstem and the vermis demonstrate normal volume. The pituitary is normal for age. There is no empty cellar to suggest possibility of raised intracranial hypertension. Going to a more magnified images along the brainstem, you can appreciate that there is this blob-like structure along the right oculomotor nerve. Better appreciated on the Swa sequences. You have this triangular area of abnormality along the exit zone of the right oculomotor nerve. Does not demonstrate restricted diffusion. No abnormalities on SWI. The corresponding sagittal images, you can appreciate again this focal T2 hypointense, T1 isointense area. It is distant from the vessel. There is no aneurysm or vascular malformation. These are the angiography pictures. Post contrast, you have this mild enhancement of the structure. The first differential what we thought of is ophthalmoplegic migraine. I'm not sure if the child presented with migraine clinically, but the findings is the MRI findings is typical of the ophthalmoplegic migraine. They have this third nerve palsy and this enhancement of the enlarged third cranial nerve in the root exit zone. And in the acute subacute phase, they can present with enhancement.
Yes, sir. So we thought like it is looking like an ophthalmoplegic migraine, and there is also a history. I want to discuss this after that imaging. So she has a history of headaches since last 5 years. That means when she was 10 years old, and she used to get a photophobia, phonophobia also during the headache. And mother has a history of motion sickness and headache during SPT time. So this was the headache, but she never took any treatment, proper treatment for this headache. She just used to take painkillers, and she had never this kind of ophthalmoplegia. This is the first time. And after this diagnosing ophthalmoplegia based on the contrast and this images enhancement, we gave her steroids. And we had a follow-up after 2 weeks of steroids and after 4 weeks of steroids. So after 2 weeks, the ophthalmoplegia has resolved of around 50%, but still she used to have diplopia while reading and while looking on extreme gaze of the right and left eye both when there is a high differentiation difference. And now after the 4 weeks, her ptosis has much, it's completely normal now. There is no ptosis, but adduction of the right eye, medial rectus, still there is some abnormality. Otherwise, other cases are she's fine. She can able to read and all. Diplopia is also, she is saying 80 to 90% it has decreased. And we also started her on Cybelium, flunarizine, along with the steroids. So we are now tapering the steroids because she had other side effects like acne, some put on weight gain. Anyway, we have started on 1 mg per kg, but still it's become almost 4 weeks. We are tapering down. So we want to just know either any differentials based on this MRI other than ophthalmoplegic migraines.
Yeah, if you gave me the opportunity, I would have gone to the differentials. But yeah, here are the differentials. Schwannoma of the oculomotor nerve is rare, but can be seen in pediatric patients. NF2 can be associated with neurofibromas, but we don't have any NF changes at the moment. Aneurysm or vascular malformations can be seen. Other differentials in a more younger age group is ATRT. They can have restricted diffusion and exponential growth for a short period of time. Leukemic infiltrates and carcinomatosis are other differentials. Non-neuroplastic changes such as inflammatory conditions, sarcoidosis, and can also present with these changes, but they're usually bilateral and not isolated. So based on the imaging findings, I would probably think of ophthalmoplegic migraine if the clinical findings fits of migraine and third nerve palsy. And the other differentials, probably rule that out on follow-up images, because here is a review of the ophthalmoplegic migraine cases. And what they found was around 9 weeks, the MRI findings decreased over persistent, whereas these neoplastic lesions, they usually do not decrease in size. So a follow-up imaging around 10 weeks, 12 weeks would be suggested for this case. And at this moment, I'll open the case for further discussion.
Hello, Dr. Rashmi speaking. LP done now? CSF? Done? Finished? Sent off for this thing. Child is okay? Huh? Sorry?
Nihaal, in my opinion,
child is okay. Okay, fine, okay. When did you do CSF? How long? Just now you did. Okay, okay. Thank you very much. Thanks.
Yeah, I can go ahead. Sorry.
The history, the onset, the clinical constellation, and the MR is absolutely characteristic for ophthalmoplegic migraine. I mean, this is a historic term. It has nothing to do with normal migraine. So in the new headache classification, it's no longer subcoded as a migraine, but among neuralgias. And with or without steroids, usually there is good recovery. It can recur or cannot, but I think there is no differential, I think.
Yeah.
Hello?
Should we call it as a recurrent neuropathic ophthalmoplegia, neuropathy, like ophthalmoplegic neuropathy? Is the latest term?
I mean, you can still call it like this. People will understand. I just want to say that it's more like an inflammation of that nerve with swelling and contrast enhancement, and it's not a usual migraine. Also, it can last for several weeks.
Okay,
but just in terms of semantics, it's not a form of migraine.
How long should we treat her, sir, with steroids?
Can you repeat?
Sir, how long should we give the steroids?
2 weeks, 3 weeks, I think it doesn't matter. The natural history is favorable, whatever you do or not do.
Okay, sir. Okay, sir, thank you.
Okay, right. Thank you. Thank you again. Next case, Ramani.
Yes, sir.
Yeah, go ahead.
Yes. So this is another case, 11-year-old male, born of non-consanguineous marriage with normal birth and developmental history. He developed seizures since 2.5 years of age in the form of initially generalized tonic-clonic seizures, and also before those GTCS were prolonged almost up to 30 minutes. And before this GTCS, he used to get the automatism like a screaming, hand flapping, chewing movements with gurgling sounds. This usually used to occur in the sleep most of the times, and we started her on the valparin initially, and the frequency has decreased from 4 to 5 episodes from per month to 3, and after adding clobazam, they were much controlled, like 1 episode per month. This was his clinical semiology at 2.5 years of age, and unfortunately the child lost to follow-up for almost 3 to 4 years because the seizures were well controlled and only 1 episode per month, so they didn't come. And when the seizure frequency has increased recently, they had come. So first we have done MRI at 2.5 years of age initially to rule out the structural causes because of the definite automatisms and all aura, and then we repeat it again now to see if there any change. So first MRI it showed. Sir, could you please share the first MRI?
Anything on the EEG? Any EEG done?
Yes, sir. EEG also showing. Yes, sir. EEG has been done. Initial EEG is still showing right focal discharges, epileptiform discharges, mainly from the right occipital and right frontal. Now it has changed. It is now the current EEG after so many years. It is showing a generalized burst from right predominance sometimes and left predominance, mainly from the right predominance. Most of them are consistent with the right predominance.
Okay. Yeah, we'll go on with the MR images.
Yes, sir.
So I have 2 sets of images. The first images are from February 2020. On top are the heavily weighted flare sequences. Nothing in the superficial areas. Cannot appreciate any cortical malformation or dysplasia. No white matter abnormalities. Coming down to the deep gray nuclei, basic ganglia and thalami are normal. There is slight hyperintensity in the peninsular or the insular cortex on the left. Moving inferiorly, you can appreciate that the left amygdala or the parahippocampal region is brighter than the contractile side. There is loss of the gray white matter differentiation. Again, on this image, you can better appreciate this abnormality. The parahippocampal and the hippocampal region are also swollen. images also demonstrate similar findings: hyperintense swollen changes in the mesotemporal lobe and the amygdala. Also, on the T2 weighted coronal images, you can appreciate this loss of gray white matter distinction and edematous changes or bulky left mesotemporal lobe.
So at this point of time, yes, sir. At this point of time, we thought some structural abnormality. So we did a surgical evaluation to see, but unfortunately, we didn't catch any seizure while doing the video EG, continuous video EG. So that was stopped, the surgical workup, and then after that he left because the seizure is also well controlled. So father did not was not willing for the surgery. And now the frequency has increased, so he again came back to us, and we repeated a seizure EEG and an MRI also to see whether those hippocampal changes, because our radiologist told it could be because post-ictal, it can remain for 2 weeks. So after 2 weeks of MRI, EEG, we can see if there is a normalization of the hippocampal area, then we can treat it as like a post-hippocampal rather than a structural.
At that point, did you do an autoimmune workup by any chance?
No, sir. We have not done any autoimmune work.
Okay.
This is a mass, isn't it, Nihaal? And you probably have some dysplasia of the fusiform gyrus next to it as well, and the parahippocampal. So this would be an ILA type 3 lesion. I don't think this is going to go away in 2 weeks or 3 weeks.
No, so it's there after 2 years. So it's definitely a mass and it's still persistent. Spectroscopy wasn't done, but I'm thinking it won't go away. This is a normal contractile side. You can appreciate that it is still bulky, loss of gray matter differentiation. So it is still persistent. Not a major temporal lobe sclerosis. I think that was reported initially.
It's a
I think it needs.
So why we have referred this case, sir? Because initially we got this MRI report as normal after 2 years. This is in May 2022. So that's why we want to discuss here. But again, we got this re-reporting of the MRI, and it showed the same changes. And that's why we will plan for a surgical workup now. And sir, my doubt is, we do ASL also while doing this ASL and MRS for structural changes or differential like cases? Do we need to do MRS and ASL? I mean, should we write in the MRI form while doing MRI 3T epilepsy protocol?
Nihaal, you want me to answer that?
Yeah, we don't do ASL here, but yeah, you can go ahead.
Yeah, I mean, ASL you can do. It's a 3-minute sequence, but the fact is that it's got a lot of artifacts. And I think, as you can see very nicely in this case, it was an abnormality always there, which wasn't called. So I don't think an ASL would have helped more in this case. In fact, it might have confused you at times as well. But for our so-called lesion negative scans, there might be a role for ASL and, twinning and other things. But with spectroscopy, I mean, unless you have a target, what are you just interrogating on spectroscopy? And if you had a target, then you don't need spectroscopy, because this is a glioneuronal tumor and it's got associated dysplasia of the parahippocampal and fusiform gyri anyways.
Okay, sir. Okay, sir. Yep. And sir, how to differentiate whether it is a post-ictal change or structural within 2 weeks of seizure? We do an MRI.
No one has been able to say that confidently, and I think we should be very wary about post-ictal changes only by itself. In the context of a mass which is space occupying out there, you can see the choroid fissure is also impinged, and signal changes extending to the to the ipsilateral gyri basically. The other thing to add here is that in children, when you pick up focal epilepsies, then you should be very wary about calling it post seizure changes only, and in the context of a child who's having recurrent seizures especially. But we wouldn't recommend an MR automatically in 2 weeks for it to go away. We don't do that.
Okay, sir. Okay, sir. Thank you, sir.
All right, thank you. To our next set of cases, Dr. Juhi, you can take it forward from here.
Okay. This was a infant. Came to us with a history of on and off fever since 1.5 months. Parents used to say that as the day used to progress, by the evening, they used to feel that the child is warm. However, there was no documentation. He came to us with an acute history with left eye ptosis and a lower motor neuron kind of facial palsy of the left side since 4 days. And since 10 days, along with some irritability. I saw the child at day 12 of illness, and I had this CSF report which had high proteins, sugar was normal, no cells. And by day 12 of admission, which was day 22 of these focal neurological deficits, there was a significant recovery. The ptosis and the facial palsy had almost gone. The child was playful, and that too only with supportive management, no steroids. Even TB was one of the differentials of the admitting unit because there was a TB contact, there was a prolonged fever, but only with supportive management there was a significant recovery. So I want to discuss that radiology wise, how can we differentiate amongst infectious versus demyelination, especially if diffusion and contrast is not helping us. Because then if it was demyelination, I would have gone ahead and treated with steroids.
Dr. Munkal, would you want to answer the question before we go to the case? Infectious, parainfectious phenomenon. Okay, we'll go with the case first and then move on to the discussion. So here are the images on top of the T288 sequences. There is generalized reduction in the volume of the supra and intertemporal brain parenchyma, more in the supratemporal brain. You can have these focal T2 hyperintensities faintly in the left thalamus and also involving the left half of the midbrain. The mammillary bodies also demonstrate hyperintense edematous changes and also along the subthalamic nuclei. You can appreciate that more on the flare sequences. Again, involvement of the brainstem, the left thalamus, mammillary bodies, corpus callosum is slightly thinned out, no restricted diffusion. Given that this is a scan at after 22 days, is that right, Juhi? Of illness?
Somewhere a little before that, so maybe by day 15, 16 of illness.
Yeah, so no contrast enhancement. The differentials would think of infectious and demyelination. I'm not sure how to differentiate them, and I'll open the case for further discussion.
What is that nodule sort of a thing visible in T2? First row, fourth cut.
This one?
Yeah, what is that rounded thing?
This is just part of the edema. It is slightly heterogeneous, but it does not enhance on contrast.
Okay, it was reported as an old healed granuloma
Sorry, I didn't get it.
Old healed granuloma. It was reported as that, and I was wondering that apart from the hyperintensities, why there is such a nodular sort of a thing.
I didn't have the GRE sequence, the SWI GRE sequences to see the falsification.
MOG antibodies have been done?
No, sir. So could not do any of the demyelination workup because of affordability, and because the child had improved so much, so couldn't much convince them for that. But my question was this only, that if you already have a significant improvement and this is the radiology, then is there any, would you call it sort of a viral encephalitis or demyelination?
Your protein is very high. There is significant cytocellular dissociation with a normal sugar. So one of your prime differential in that sort of situation is a demyelinating illness, unless you're looking like something like a Freund syndrome, those kind of conditions, which is obviously much more uncommon than a demyelinating disorder. So I think still possibly the area of the lesions, including thalamus and the midbrain and the areas involved, still would be possible with a demyelinating disorder along with your CSF going hand in hand. Having said that, we have had children with tubercular meningitis where the CSF was reported to have slightly high protein and normal cells. Later on, CSF had shown significant worsening. But this child has improved, so obviously it is not tubercular in nature. Still, I think the money would be on the demyelinating kind of disorder.
Okay, sir.
Prof or Kish, any inputs on the radiology to differentiate?
Kish is not there, but
We'll go ahead then. Yeah.
But your differential diagnosis
okay.
is
Yeah, no problem.
is
Dr. G, next case.
versus viral infection. Did I get your point?
Yes, sir. Yes, sir.
So
yeah.
you have not yet started with steroids.
So I did not. In this case, there was a significant recovery. So I have discharged them and called them for a follow-up within a week. And I plan to follow this child.
Is there a risk to start with steroids for some days? What can you lose something? Can you gain something?
Sir, I could have, this case could have been treated like demyelination. So could have been treated with steroids, with pulse followed by oral steroids. That would be, there would be a slight risk of infections, but then it would also give a benefit of complete recovery maybe.
Okay, I would consider to give steroids. I mean, this may be not in all situations, but for example, in herpes encephalitis, if you add steroids, this does not lead to any deterioration, maybe no change, but perhaps also improvement.
Okay, okay, sir.
Okay, great. Thank you. We'll move on to our next case.
This child, yes, this child is currently 4.5 years of age, and there was a significant perinatal history that there was a delayed cry, admission for term baby, delayed cry, admission for 20 days, and the discharge card says HI stage 2. And there is a static course with gaining milestones, and clinically he also has drooling and spasticity. But these signal changes in the radiology were going up to the subcortical areas. So I wanted to discuss whether these are typical term HI changes or I should look beyond and go ahead for a genetic workup.
Okay, but clinically static course improvement that would favor post-acquired cause, if I'm not mistaken.
That would favor a perinatal insult.
Yeah, but it's a term child with delayed cry after delivery and no antenatal factors.
No antenatal factors.
Maternal. Okay.
No maternal or neonatal risk factors.
Okay, so we have some degree of volume loss in the supratentorial brain. There's also some periventricular reduction in the volume, predominantly in the posterior periventricular regions. Posterior fossa, I cannot appreciate any abnormalities. On the sagittal images, the corpus callosum is thinned out more posteriorly and along the middle aspects as compared to the anterior segments. But as you have mentioned, on the flares, you can appreciate these confluent homogeneous hyperintensities. They are going up to the subcortical regions, superficial periventricular white matter changes. The deep gray nuclei for a term child with HIE, commonly we see some area of gliosis or volume reduction, but I cannot appreciate that on the T2 and the flare images. Cerebellum, no signal changes on the flare. Brainstem also. No abnormal mineralization or hemorrhage, old hemorrhage on the SWI sequences. So for a term child, the imaging finding is little atypical for a sequelae of HIE. Even if we think of these changes of validated degeneration or gliosis, the parenchymal sulci are relatively well preserved. We would appreciate some areas of widening of the sulcation pattern, given if there's some gliosis, and the periventricular pattern is not typically seen in the term child. They are more in the watershed territories. So I would favor a non-hypoxic injury related leukoencephalopathy based on the imaging alone, but I'm not sure of the static encephalopathy if it favors a genetic cause for this patient. So I'll open the case for further discussion.
With the static course, it might still be a genetic etiology. Another thing, if we don't look at the perirolandic or the basal ganglia changes, can the changes of perinatal asphyxia go up to subcortical white matter?
For a preterm child, yes. For a term child, they are usually in the watershed pattern. They can go up to the cortex and subcortical region. But diffuse involvement is pretty atypical. They're usually seen in the anterior and posterior watershed territories. Cortex and the subcortical regions can be involved with gliosis.
Okay.
But here the cortex is relatively well preserved. There is no thinning of the cortex. It is predominantly a white matter disorder.
Okay. And what do you think about the ventricular lining, especially the parieto-occipital, the posterior horns?
It is. You mean of the signal changes or the volume? It is definitely there's reduction in the volume of the white matter.
Okay. Okay.
Just clinically, as you have said, they can present with static and static changes and data on progress. So genetic possibility is still active.
Right. Are there slightly unusually prominent veins? Sorry, unusually prominent veins, or just a prominent on the FLAIR images?
No. Veins. I think they are sulcate. They are just sulcite.
Okay.
No, they would have been demonstrated on the SWI if they were prominent veins.
Okay, sure.
Can I come back? What is now your conclusion? Is that acquired or not? I mean, this is not the typical image you would expect in a term baby following HIE, but the patient has kind of cerebral palsy, is stable and makes even progress according to the previous slide. This is...
Yeah, that was the only question. Again, there was some mismatch. So I was not sure how they present neurologically, if it's possible or not.
Gaining milestone. So he's improving.
Yes, sir. So he has a static course with gaining milestones. He has gained motor as well as language milestones. He started to speak. And he also has drooling, which, so drooling, squint, all these also points towards a perinatal insult. There is no progression. But then again, certain disorders like those cobalamin pathway defects, some of those urea cycle defects, or some organic acidureas. So some of these metabolic genetic conditions can also have a static course. So we cannot be sacrosanct about this static course.
But you have a strong history of a perinatal problem, and the child was 3 weeks on ICU.
Yes, so 3 weeks in ICU, although no ventilation. So that was the question, that we do have a history, but looking at these changes did not look typical.
The imaging changes, are they slightly asymmetrical?
See, on the FLAIR images, they look pretty uniform on both sides.
Clinically, there is mild asymmetry. Right is more affected than the left. Mild, but it is there.
Yeah. So I think the perinatal history and the static course and the epidemiologically it more favors a static perinatal insult. I think the imaging probably is not very classical for a child.
Yeah. What is the follow-up protocol you're doing, Dr. Juhi, for this child? Genetics or wait and watch?
So I've just seen him once. He just came. So I think I'll follow. And this is the first child of the parents. So I'll give them an option. If they do plan to extend the family, I'll give them an option. And if I do genetic testing, then I'll give a feedback.
Sure. All right. Thank you.
Thank you.
Okay. Next case again from Dr. Juhi.
So this was a 12-year-old previously developmentally normal child, and she presented with a fulminant course. So there was a previous history of on and off fever going on for 7 to 8 weeks. Again, undocumented evening rise temperature. But she came in, she was symptomatic since 25th of May, and in the form of status, seizures, encephalopathy, and got ventilated on day 1. We could do a CSF, again, high protein, normal sugar, no cells. And looking at the radiology, I suspected demyelination, although I also suspected some hemorrhagic components, or maybe hemorrhagic demyelination. My possibilities were MOG, GFAP, or CNS HLH, or there was a thalamic involvement, so ANEC. But I could not do much workup. We lost this child yesterday. Very fulminant presentation. We could pulse and as well as give IVIG. Could not save her. But then I still wanted to discuss the radiology.
Sure. Thank you. So on the images, the T2 and the flare axis, you can appreciate confluent areas of abnormalities involving the white matter, the frontal and parietal regions in the right and left cerebral hemispheres. There are some areas of hypointensities within these changes, probably suggest of demyelination. Bilateral basal ganglia and thalami also demonstrate these edematous changes. Also in the external capsule, the parenchyma regions demonstrate these T2 hyperintense changes. Brainstem and also the vermis and cerebellum demonstrate these focal patchy abnormalities. Where you can better appreciate the confluent lesions extending up to the corpus callosum, also involving the bilateral deep gray nuclei and the posterior limbometal capsules. Sagittal images, you can appreciate the involvement of the corpus callosum, also the brainstem. Diffusion weighted sequences, there were areas of restricted diffusion within the right frontal white matter abnormality, also the corpus callosum and the bilateral thalamic regions. The brainstem, the loss of brainstem changes also demonstrated restricted diffusion. This child did not have an SWR or GRE, so could not ascertain if there was hemorrhage or mineralization, but I think there were some tiny foci of T1 hyperintensities, but not in the thalamus. They were in the frontal white matter and the cingulate cortex. Post contrast cannot appreciate any enhancement within the abnormalities. Possible tigroid, but not very significant or clear cut. No ring-like or peripheral enhancement in the thalami, and also no enhancement in the brainstem. No meningeal enhancement also. Imaging possibilities. First one, we thought of ANEC. ANEC can have infectious mimickers such as dengue encephalitis, influenza, Japanese encephalitis. GFAP, as we have seen recently from cases from Dr. Vivek, can have these confluent abnormalities. They can have these tigroid pattern of enhancement or can have more of a confluent areas of abnormal enhancement. These are again the typical perivenular enhancement in GFAP astrocytopathy. HLH, I think was less on the, at least on the imaging differentials, because they predominantly present with cerebellar involvement, bilateral areas of abnormal involvement in the cerebellum with contrast enhancement. Supratentorial brain parenchyma can present with confluent changes involving the white and deep gray structures. They later on progress to atrophic changes in the brain parenchyma. But HLH is slightly lower down on the imaging pattern. So ANEC, GFAP present with these findings. At this point, I'll open the case for discussion.
In ANEC, we should get a target sign. Usually, not always. And do you see these patchy?
Yeah, but
I would keep demyelination ahead of ANEC because there are these patchy white matter changes, no target sign. What would you say about that?
Yeah. So there is restricted diffusion going on there. This can later on present with the target sign on the contrast or the SWR sequences. About the white matter abnormalities, this is a publication from the AJNR. As you can see, they can present with this confluent white matter abnormalities along with the deep gray nuclear changes. So ANEC is not completely ruled out. Yeah, confirmed. So these are from literature, and these are all cases of ANEC. So as you can see in this panel, white matter abnormalities here and also extending up to subcortical regions.
Okay. So that was one of the possibilities, but here they were too patchy. So
given the permanent course, would you favor ANEC over demyelination?
So ANEC usually has a good outcome, even if they get vent. So we have 4 cases of ANEC secondary to dengue, and all were ventilated for a long time, and they all are now modified Rankin 1 or 2. So usually it does not have that bad a prognosis, but never know with thalamic involvement.
Juhi, I think we have a completely different outcome. For ANEC, it's almost 50% mortality within 36 to 48 hours. And rest of the survivors, hardly few are been able to walk. Around 60 children we have follow-up. and with more than 50% mortality and another 25% they have bed-bound, tracheostomized, and so that's a kind of outcome. Only slightly better outcome when we have used tocilizumab within first 36 hours. But rest of them have very, very fulminant course. I'm surprised with 4 good outcomes, good for the children, but in general, that is the sort of outcome what we have seen.
Okay. Our cases were, sir, they were ventilated for 20 to 27 days. And although they all 4 were dengue positive, so maybe the outcome differs from agent to agent. And would you keep INEC as upfront or demyelination in this case, sir?
In this case, differentials have to be considered because you have not seen necrosis very clearly, although the images are not available. Slightly patchy, they are more symmetrical. But the fulminant course would slightly point towards any kind of pathology is what we are also thinking. Because ADEM, the demyelinating illness, unless it's causing significant mass effect, it would lead to early death.
Right, right. Okay.
Yeah.
Okay, right. Thank you.
Thank you.
And last 2 cases. Do we have Dr. Ankush on board to present his case? Okay, I'll go ahead with the case. So this was a 3.5-year-old child presented with acute encephalopathy. The MRI was done during the encephalopathic episode. Previously, the child also had motor delay, walking after 2 years of age with speech delay. Lactate, blood gas, urine ketones, and CBP were normal. Moving on to the images. This is at the age of 3.5 years. So there is some abnormal white matter changes in the superficial white matter and also in the subcortical regions for a 3.5-year-old child. But the predominant change is in the global paradise, which is edematous and swollen. Symmetrical changes. There's unilateral involvement of the cerebral peduncle on the left. No abnormalities in the cerebellum, at least on the T2-weighted sequences. Again, here you can appreciate these white matter abnormalities associated with the bilateral global pallidi abnormalities and the left cerebral peduncle abnormality. Restricted diffusion is demonstrated in the bilateral global pallidi. There were some areas of restricted diffusion in the vermis and the cerebellum. ADC was not there, so I'm not sure if it's T2 shine through or true reversal. But as you can see, compared to the other parenchyma, there is some bright signals on the diffusion-weighted sequences. Post-contrast study, there is some peripheral enhancement, possible demyelination going on there. Otherwise, there's no other significant areas of enhancement. Given the primary involvement of the bilateral global pallidi, these were the differentials, I think, on the imaging to be considered. Organic acidurias and mitochondrial disorders are the prime differentials. Other abnormalities such as beta-ketothiolase, creatine deficiency, pyruvate dehydrogenase deficiency, methylmalonic are differentials on imaging. At this point, I'll open the case for the discussion, if anyone has any further comments. There was no ophthalmoplegia. Kern-Sens syndrome can also present with subcortical white matter changes and DBA nuclei changes. But there was no ophthalmoplegia, so I think that would be less likely. Okay, if there are no further comments, we'll move on to our next case. This should be our last case. Geeta, if you're there, you can present the case.
Yes, sir. This child was a 7-month-old female child born to 3rd-degree consanguineous parents and had a normal perinatal and developmental history. So presented with paroxysmal events in the form of crying, uprolling, and tonic posturing, had some 3 to 4 such episodes. Then followed by encephalopathy, fever, and oxygen requirement was there, sir. So during the hospital stay also, there was on and off fever and oxygen requirement was on and off, encephalopathy, not recognizing mother. And examination wise, AF was at level, extraocular movements were fine. There was poor fixation and tracking. Pupils were normal size reacting to light. And there were generalized dystonias from the day one of the presentation, and also pyramidal signs in the form of bilateral gastrocnemius spasticity was there. Also striatal toe with brisk TTR, that is both pyramidal and extrapyramidal signs were there. So fundus examination, when we have done, there were like retinal hemorrhages, something like that. So we took a formal aphthal evaluations. Before that also we done an NSG, it was normal. And before the aphthal evaluation, MRI was done. But MRI changes were like different. So we wanted this case to be discussed whether like what is the correlation of these clinical findings with the MRI, and what are all the differential diagnosis to consider, and experience of other people over here. And investigations likewise, there was much inclusive, like only initially lactase was elevated, otherwise TMS, CSF studies, coagulation profile, everything turned out to be normal.
Okay. Going on to the images, we have diffusion and ADC sequences, and there is extensive area-restricted diffusion predominantly in the peripheral regions of the brain parenchyma. So, subcortical and cortical regions demonstrate restricted diffusion. The basal ganglia also demonstrate a certain degree of restricted diffusion. Cerebellum also has these bilateral changes of restricted diffusion. So, an extensive cytotoxic injury involving the supra and infraterminal brain parenchyma with relative sparing of the thalamus and the brainstem. T2 and FAIR demonstrate corresponding edematous changes as we have seen on the diffusion weighted and ADC sequences. No herniations, no midline shifts, but again, diffuse edematous changes in the peripheral vein and basal ganglia, and also in the cerebellum. Coming to the SWI sequences, you can appreciate that there are areas of bridging vein thrombosis, these linear regions, in the superficial frontoparietal brain, and there was subdural hemorrhage along the falx cerebri and also in the tentorium cerebelli, extending into the posterior fossa on both sides. On SWI sequences, there is a focus of SWI blooming on the left dependent portion of the orbit and also on the right orbit. There were a possible suspicion of retinal hemorrhage was raised based on the imaging. The constellation of findings of diffuse excitotoxic brain injury, subdural hematomas, bridging vein thrombosis, a possible retinal hemorrhages, the possibility of abusive head injury was raised based on the imaging. And does it fit clinically, Geeta?
Clinically, it is fitting, sir, but we went ahead and asked for the history, but we couldn't get any pointers from history. But we want to know what explains the ALE-RD picture in the MRIs.
It is hypoxic injury rather than ALE.
But there was no any evidence like hypoxia was not there in the history, sir. Only just the encephalopathy and the oxygen requirement was there.
No, I think at the time of the handling of the child, they can be. I wouldn't expect a patient with abusive head injury to give positive history of hypoxia. I think the parents usually don't reveal this abnormality, if I'm not mistaken. Just to point out the differential discussion on the differences of retinal hemorrhages, does the fundoscopy or the ophthalmological examination fit retinal hemorrhages of abusive head injury, Geeta?
Yes, sir. There was multiple like subhyaloid and subretinal hemorrhages was there, sir.
Okay.
And also one more thing is there was an involvement of the infratentorial region also.
Yeah,
so how would that fit? Cerebellum, cerebellum involvement.
Yeah, cerebellum was slightly atypical for at least a isolated hypoxic injury. But I'm not mistaken. There's a paper from Texas which had looked at 57 patients with, I have not put it up, but they have looked at 57 patients with suspected abusive head injury, out of which 21 had positive cerebroxic edema. And in those 21 changes, patients, 2 patients had cerebellar abnormalities. They have not put in the images of the cerebellar changes, but they have mentioned that 2 patients had cerebellar abnormalities. And before we open the case for discussion, I'll just review the mimics. These are various mimickers for a non-accidental injury. The triad of changes, that is subdural hematoma, fractures, and retinal hemorrhages, can be seen in accidental head trauma, birth-related injuries, and infections. Isolated changes can have various other differentials. So here are just again possible mimicas or differentials for child with abusive head injury. Infection, I think we do not have any infective focus, at least on the CSF, but they can present with these diffuse cytotoxic brain injury, subdural hematomas. No findings of glutaric aciduria. Best was ruled out. Menkes, there are no changes. Birth-related injury is usually convexity related subdural hematomas, nothing in the anterior or supratental brain parenchyma. No history of rickets, no history of Dego's disease or hemorrhagic disease of the newborn. So here are just differentials for the imaging pattern. And at this point, I'll open the case for further discussion.
My experience, of course, is limited, but I've seen a few cases where shaking was most likely the cause. And these patients had onset with acute status epilepticus, very severe, and have had interhemispheric blood initially. And this may be a spectrum. I have not considered this kind of abusive head trauma in this case, to be honest. I was impressed by the fever and the tonic posturing. Yeah.
I've seen a lot of cases of abusive head trauma when I was in England. We would do a skeletal survey to see if there was any other injury anywhere else.
It was normal, ma'am.
Oh, okay, fine, okay.
Also suggested for a skull CT, just to look for any minor fractures.
Yeah, CT scan as well, yeah, CT brain.
Yeah. But the retinal hemorrhages do they narrow down the diagnosis, Aidan?
So?
No, the retinal hemorrhages, the other differentials usually don't have them. At least the bilateral, multi-layered hemorrhages are not
The
commonly
multi-layered
seen.
hemorrhages are typical of this non-accidental injuries.
So the cerebellar involvement, cerebellar involvement, are they seen?
Dr. I could not find the imaging in literature, but they have mentioned a few cases with cerebellar involvement. I can send you the paper. It was published in 2018 or 19. But they have mentioned out of 21, 2 cases had cerebellar involvement.
Okay. Okay.
I don't know the situation, and of course I would not dare to make the diagnosis or to reject the diagnosis, just to call attention that in the recent, say, 1, 2, 3 years, there are numerous papers in the pediatric journal from Scandinavia, Acta Pediatrica, and they discuss multiple times the problem of retinal hemorrhage and so on. So a lot of questions whether this alone is sufficient, a good argument to call this abusive head trauma. I just want to, I don't want that you reject the diagnosis, but I just want to make a lot of uncertainty because it has a major implication for this family in terms of legal situation and so on. So it has to be very carefully balanced.
Just a problem in this situation as well, Prof. So unfortunately, there is no legal framework properly laid out to protect these children. They go back to the family because difficult to establish, have a separate social system to look after these children until the causative thing is established. So unless we get a clear picture, unequivocal, some unexplained fractures or multiple staged injuries, or some skin markers, it's always a challenge.
Thank you.
All right. Thank you, Dr. Lokesh. I'll send the case to Dr. Mankad. He does the MNC cases in UK. I'll probably get his opinion.
Very helpful. Yeah, that will be very helpful. Yeah, thank you. Thank you.
All right. Thank you.
Thank you.
Okay,
So
thank you very much.
On 17 June.